Welcome to Chapter 15. Today we'll be talking about psychological disorders. First, we'll discuss the historical context of mental illness, and we'll do this pretty briefly. Then we'll discuss the criteria for defining mental illness and for categorizing mental illness. Then we'll identify the strengths and weaknesses of our current diagnosis system. And then what we'll be spending the most time on today is we'll define and describe different psychological conditions by type of disorder. So this, again, will just make up the bulk of what we're talking about today because there are obviously a lot of different psychological conditions to discuss. So we will very briefly talk about historical conceptions of mental illness because your textbook doesn't spend a lot of time on historical conceptions. And also, the history that your textbook discusses is pretty specifically European and Western. So it's not necessarily a full spectrum of how we've conceived as human beings of mental illness across time, rather, the very specific conceptions of mental illness that we're talking about. So in the Middle Ages in Europe, they used the demonic model of mental illness, and they believed that mental illnesses or behaviors were the results of spiritual or demonic influences. And you still see a little bit of this today, basically in some places where maybe Catholicism is still very present, there is still the idea of potentially spirituality or spirits influencing people's mental illnesses. And this does seem to pop up in sort of religious communities, that certain types of mental illness may be because of something spiritual or something demonic. Then during the Renaissance, they started to take more of a medical approach. They began to believe that mental illness was the result of a physical disorder. And during the 15th century, European governments began to actually place individuals with mental illnesses into asylums. So they actually began to try and treat people with mental illnesses in an asylum, and they did this through certain methods, which we would obviously not agree with today, including things like bloodletting. So during this period of time, although they were maybe more enlightened than they were during the Middle Ages, people with mental illnesses would be chained up and restricted and injured and abused within the asylum system. And unfortunately, the system of institutionalization and the system of placing the mentally ill into an asylum continued well through the 20th century. Although in the 18th or 19th century, moral treatment began to be used, which was an approach to mental illness calling for dignity, kindness, and respect for those with mental illnesses. Although we could argue that that we still today don't really treat for those with mental illnesses with as much dignity, kindness, and respect as they deserve. So although moral treatment began to be integrated within asylums and institutions, we could still describe a lot of how institutions treated those with mental illnesses as deeply abusive. So in the modern era, there was a kind of dramatic change in how we treated those with mental illnesses with the introduction of the brand name is Thorazine, which reduced the symptoms of some mental illnesses like schizophrenia. And it became clear that medication could be a kind of option for treatment for those with mental illnesses. And because of the introduction of certain medications for those with mental illnesses, governments began to actually deinstitutionalize the psychiatric hospitals. They began to slowly release hospitalized patients into their communities instead of caring for them as a governmental agency. So although deinstitutionalization allowed for, it allowed for less abuse to take place in an institutionalized fashion, Although, psychiatric institutions were generally unhealthy places, releasing people who needed psychiatric help into the community also led to problems for these individuals because there was no follow-up or continued treatment. And this is still an issue that we have today, that we don't necessarily, as a society, treat those with mental illnesses, again, with kindness, dignity, and respect, but we also don't provide social services for those, or easily accessible or widely used social services for those with mental illnesses. And often there is limited follow-up and continued treatment, especially for those who don't have as much privilege or financial access. So this is just this is a super brief historical overview. And I especially think this discussion of the modern era can give you more insight into kind of where we are today, because I'm not sure that we've really reconciled with how we as a society deal with mental illness. We'll move into asking that big question, what is mental illness? And although we have criteria for defining and categorizing mental illness, I think over the next couple of slides, you'll see why it can be so difficult to define and categorize mental illness. However, with that said, the criteria that currently exist include that mental illnesses tend to be statistically rare. They include subjective distress, impairment, societal disapproval, and some sort of biological dysfunction. So now we'll discuss the different criteria of mental illness in turn. And we'll start with statistical rarity. So the majority of mental illnesses are not represented in the larger population, right? The majority of people don't have mental illnesses, or they don't have a specific mental illness. However, with that said, of course, statistical rarity doesn't necessarily capture everything that there is to capture within a definition of mental illness. So there are, of course, things that are statistically rare that aren't representative of mental illness, like something like red hair. So red hair is exceedingly rare. However, it is not representative or a type of mental illness. On the other hand, something like depression is actually quite common. Most people will experience at some point in their life a bout or an experience with depression. Although major depressive disorder is a little bit more rare, depression is exceedingly common. But of course, depression we would consider to be a mental health problem. So although depression isn't necessarily statistically rare, we would maybe characterize it as a type of mental illness, or at least a type of mental health problem. The next criteria is biological dysfunction. So most mental illnesses are represented somehow either through your genetics or, well, really through your genetic predisposition to acquiring mental illness, and also then your genes then also influence the neurotransmitters in your brain and also your hormones. So people with mental illnesses will see significant biological dysfunction. They will have more or less of certain receptors, or their brain areas for certain skills might not be as developed as other people's. However, with that said, there are also types of mental illnesses that don't seem to be represented biologically or don't seem to be connected to genetic predisposition. So extreme phobias, for example, don't seem to be tied to any sort of biological dysfunction or genetic predisposition, and instead have more to do with environmental influences. And phobias can be mostly acquired through environment rather than being tied to any sort of biology. The next criteria is inability to function or impairment. So not being able to function within society, not being able to keep your personal relationships or hold a job down or pay your bills on time, or any of the other, demands that life places on us. The majority of mental illnesses will get in the way of our ability to function. However, there are certain characteristics that people have that impair their ability to function in normal society. There are people in the world who are maybe a little lazier. They don't have the same kind of work ethic or desire to do as much stuff. And there's, people who maybe aren't functioning as well in their jobs or in their personal lives. And it's not because they have a mental illness. Sometimes people just don't necessarily want to participate. They don't hold a job down well because of, maybe an excess of privilege, and they've never had to really work hard, so they never developed those skills, and now they're not really a functioning member of society. But we wouldn't call somebody like that mentally ill. Comparatively, there are people who are actually quite high functioning despite mental illness. And I don't think we can consider alcoholism a type of mental illness. However, with that said, there are lots of alcoholics who probably need help, but who are fully functional. So they can go to work, have positive personal relationships, they can engage in the world. However, they do have a problem and an issue with alcohol. The next criteria of mental illness is subjective distress. So those with mental illnesses often have, a lot of emotional distress. Somebody with depression feels extreme sadness, they feel listlessness, they feel loneliness and hopelessness, all of which are discomforting and distressful and emotionally taxing. Similarly, those with anxiety feel a great deal of fear, which is an uncomfortable emotion, right? However, with that said, there are those who have mental illnesses who don't feel subjective discomfort, and in fact, some of them seem to have the time of their lives. Somebody who's going through a manic episode will sometimes report that they felt amazing during their manic episode, that, it feels as though it's a high of mania. So somebody who's going through a manic episode will have, inability to function. They might not be able to hold down a job or keep a close personal relationship going, or be able to fully stop themselves or use impulse control when they are potentially participating in extraordinarily risky behavior, but they wouldn't necessarily report subjective discomfort while they're participating in dangerous and non-functional activities. Then we have social norm deviance. That one characteristic of mental illness is that they aren't functioning as expected. They aren't functioning within social norms. However, of course, there are all sorts of other types of social norm deviance that we wouldn't consider mental illness. The example your textbook gives is that, they say racism isn't accepted in society, and we can maybe disagree on how much racism is accepted in society. I wouldn't say it's totally unacceptable. However, we don't think of racism as being an example of mental illness. So although it's not a social or societal norm to be racist, it's still not a criteria of mental illness. Similarly, people who are rude, who may not act within the kind of social norms, maybe they jump in line or they're super late to things, people who are generally rude aren't participating within social norms, but they also don't have mental illnesses. Social norm deviance has also, as a criteria, has been exceedingly problematic. Historically, gay people, LGBTQ people, were considered mentally ill in part because they did not fit into a societal norm. But of course, and very clearly, somebody's sexual preferences really have nothing to do with their mental health, apart from, societal pressures potentially negatively influencing their mental health, but the actual sexuality is not the cause of any sort of mental illness. However, because of a criteria like social norm deviance, we can classify any sort of, more rare behavior or less typical behavior of the general population as being a form of mental illness. And of course, that is and can lead to some exceedingly problematic diagnoses. So what this tells us is that none of these characteristics are sufficient on their own, that we can't say that a mental illness is defined by the fact that it's statistically rare, just like we can't say that it's defined by the fact that there's subjective discomfort. Additionally, we don't need every single one of these criteria for something to be a mental illness, right? So somebody with bipolar disorder who's going through a manic episode will experience social norm deviance. Bipolar disorder is statistically rare. There's usually biological dysfunction going on and inability to function. However, they aren't experiencing subjective discomfort. So none of these characteristics on their own are sufficient, and not all of them are necessary to maybe classify a mental illness, but these are helpful when we discuss and classify and categorize mental illnesses as kind of a definitional guideline. There are also other factors when it comes to mental disorders that are important to consider, even if they don't necessarily function as well as criteria. So other factors that are important to consider are things like whether or not somebody is a danger to themselves or others. Although somebody being a danger to others isn't as common, suicidality is significantly higher among those with mental illnesses. So they could potentially harm themselves. Additionally, whether or not somebody needs treatment. Some people with mental disorders report feeling a loss of control over their own behavior. Another important factor to consider is the amount of variation in a disorder. And this is both between individuals, right, when it comes to severity, and also between cultures, that in some cultures, certain mental disorders may not be as negative or present as negative as they do in others. Just as culture is an important discussion in psychology as a whole, it of course is important here in our discussion of psychological diagnoses and mental disorders. So it seems as though some syndromes are culture bound, that they are more prevalent in some cultures or exist only in some cultures. For example, there is something called a muck, which is a syndrome that is culturally bound to only a few countries, including Malaysia, the Philippines, and then some African countries. And a muck is characterized by going wild, and it's, first there'll be intense sadness and brooding, which is then followed by uncontrolled behavior, which sometimes does also include extreme violence. So a muck isn't something that we see in other cultures or in other countries. It seems very specific. That doesn't mean that it is not a real syndrome, because it does seem to have very specific criteria that are consistently pop up within these cultures. So what this means and what this kind of suggests is that although in the last slide or the last couple of slides, we were talking about how mental illnesses are defined by the fact that they are, that people develop behavior that is not bound by social norms, right? However, with that said, even odd or abnormal behavior still seems to be shaped by social norms or cultural norms. So culture still plays a role in these psychiatric diagnoses. Some conditions aren't necessarily bound to only a few specific cultures, and instead vary in their presentation across cultures, or vary in their probability across cultures. So something like social anxiety is something that a lot of people experience. However, it's manifested very differently depending on culture. In Japan, which is again more of a collectivistic culture, people may have a fear of offending other people, offending others in their group. Comparatively, in the US, which is a more individualistic culture, social anxiety has more to do with fear of public embarrassment or making a fool out of yourself. So one has more to do with kind of the feelings of individuals within your group and the other one has more to do with a fear of something to do with yourself. Additionally, some disorders are more prevalent depending on the country. So eating disorders are significantly more prevalent in the US and Europe than they are in other countries. And in fact, eating disorders don't necessarily exist everywhere in the world. However, with that said, as we connect more and more to each other through things like the internet and media, ideals of beauty also spread through these kind of communication tools. So unfortunately, eating disorders are now on the rise outside of the US and Europe as kind of those cultural norms surrounding beauty also begin to spread. However, with that said, there is some cultural universality in that some disorders do seem to exist in all cultures. Schizophrenia, alcoholism, and psychopathy are all disorders that exist in all cultures. It seems as though there's something universal about schizophrenia, alcoholism, and psychopathy, which may indicate potentially a closer relationship to genetic predispositions for these disorders. So we kind of just discussed some of the difficulties involved with characterizing and defining a mental illness. We're about to move into some of the diagnostic tools that are in use today. So it's important to also consider why psychiatric diagnoses are important or helpful. Why do we actually need to define something that can be pretty nebulous, right? First, it helps us pinpoint the psychological problem a person is experiencing. So this can make it easier to select a treatment. Somebody with depression is going to need significantly different treatment than somebody with schizophrenia. The same goes for bipolar disorder or any of the other mental illnesses that we'll discuss today. Additionally, psychiatric diagnoses make it easier for mental health professionals to communicate with each other. It basically creates a verbiage and a language that makes it easier for everyone to kind of understand what we're talking about. So although psych diagnoses can be difficult and they can, there are some methodological concerns when it comes to a psychiatric diagnosis. They are extraordinarily helpful both for patients and for mental health professionals. So the DSM-5 is probably the most famous and most used diagnostic criteria or diagnostic manual. And what the DSM-5 stands for is Diagnostic and Statistical Manual of Mental Disorders, and the 5 stands for the 5th edition. So the DSM-5 is the most recent edition, and it's a diagnostic system containing the American Psychiatric Association, the APA. It contains their criteria for mental disorders. So some example of criteria. So the criteria that someone would have to meet in order to be diagnosed with a disorder. So to be diagnosed with a major depressive disorder, you have to experience 5 of 9 symptoms. So these symptoms include fatigue, insomnia, significant weight loss. They must experience depressed mood or diminished interest in everyday activities. So somebody with depression must experience either depressed mood or diminished interest or both in order to be diagnosed, and then some other combination of the other symptoms within the diagnostic criteria. So they don't have to have every single criteria in order to be diagnosed, but they need at least 5 and 1 of the depressed moods or diminished interest, so apathy. So some other important factors with the DSM-5. First, that the DSM-5 warns that some physical or medically induced conditions can simulate certain psychological disorders. So the DSM-5 wants to emphasize that because somebody is experiencing certain symptoms or certain criteria, that there may be kind of organic causes of their behavior. So something like hypothyroidism often is associated with certain, can mimic some of the effects of a psychological disorder, even though it is more physical than psychological in nature. So hypothyroidism can cause things like fatigue and apathy, which can be linked to something like depression. Additionally, in extreme cases, hypothyroidism can cause hallucinations. So people may get symptoms of hypothyroidism confused with depression, or more concerning, conflate the symptoms with psychosis. The DSM-5 is also helpful because it provides information about the prevalence of mental disorders. It provides us with a percentage of people within a population who have a specific mental disorder. So this is obviously really helpful when it comes to maybe shaping public policy or where we should divert social services. It's good to have an understanding of the actual prevalence of certain disorders or diagnoses. There are, however, some issues and criticisms surrounding the DSM-5 that we'll review here. The first issue with the DSM-5 and the first criticism is that there's often a lot of comorbidity. So comorbidity is the co-occurrence of two or more diagnoses within the same person, which makes it difficult to tease apart conditions. Some types of diagnoses are more comorbid than other, meaning that they are more likely to kind of appear together within the same person. And the question here is, if there's a lot of diagnoses that are highly comorbid and occur, the two occur within one person quite often, that makes us wonder whether or not we're actually diagnosing independent conditions as opposed to slightly different variations of one underlying condition. So for example, anxiety and depression are both highly comorbid with one another. Something like 60% of people with anxiety also experience depression. And it's unclear exactly why this is happening, but one of the questions is, are we really diagnosing two different things if anxiety and depression are so similar? And ultimately, the biological mechanisms for anxiety and depression resemble each other quite closely as well. With that said, they do tend to present themselves very differently. So there do seem to be different symptoms for these two disorders, but potentially there may be some sort of relationship there that by separating them out into two independent diagnoses, we may be missing another part of the story. And when we treat diagnoses as being completely separate from one another, that does also limit our research on these disorders and how they interact with one another. Additionally, the DSM-5 relies on a categorical model instead of a dimensional model. So a categorical model is one in which a mental disorder differs from normal functioning in kind rather than in degree. This means the disorder is either present or absent. As we were discussing earlier in the chapter, many people have experienced some sort of depression in their lifetime. However, most people couldn't be classified with major depressive disorder. However, depression is quite common. And this is where maybe a dimensional model might fit better. A dimensional model is one in which a mental disorder differs from normal functioning in degree rather than in kind. Again, depression and anxiety may lay on a continuum with normality. Somebody with major depressive disorder may just have, severe depression that everyone else also experiences to a lesser degree, rather than some people having major depressive disorder and then everybody else having normal functioning that also includes sometimes depressive episodes. So basically, a categorical model might make diagnosing easier, it might make research easier, it might give us a better idea of the actual statistics of mental disorders. Mm-hmm. However, it can be uninformative when it comes to how mental illnesses actually present themselves within a population, which again is often on a spectrum from severe to non-severe. Recently, a new form of diagnostic criteria was launched called the RDOC. So the RDOC is a program of research designed to classify disorders in terms of deficits in brain circuity. Now, this aims to supplement the DSM-5 rather than replace it. So instead of focusing on the actual symptoms of mental disorders, this works to incorporate multiple dimensions to study and classify mental disorders. This includes things like genetics, neuroscience, and the actual nature of social interactions. So again, the goal here is to be a classification system that's more about the actual dysfunction of the biology of mental illness rather than simply about symptoms. And that might give us some more answers about the actual functioning of mental disorders and shed some light on the biological functioning of these disorders. So now your book has a whole list of misconceptions and reality, but the one that I want to touch on that I think is particularly important is the idea that people with mental illnesses are more violent and more dangerous. And that's not really true. The vast amount of people with psychotic disorders, like something like schizophrenia, don't actually present physical aggression more than the average person. And actually, they're more likely to be the victims of violence. So those with mental disorders experience significantly higher rates of victimization than those without mental disorders. With that said, those who believe that they are being persecuted in some way are more likely to be physically violent than those with other types of mental disorders. So something like substance abusers. So somebody who's addicted to something who might fear going to jail is more likely to be physically violent. I think part of the problem with how we conceive of mental illness is not fully understanding the diagnostic criteria. So something that I've seen is when somebody is particularly violent, people assume that they must also be insane. But violence is, again, not something that is only committed by those who are mentally ill. There are abusers and murderers and people who commit violent acts or aggressive acts all the time who don't actually have a mental disorder. And that's important to recognize, that because somebody is violent, that does not tell us that they are more likely to have a psychiatric condition. A prevalence of violence doesn't really tell us much about mental health. So I think this myth is particularly important to touch on for a few reasons. The first is that believing that the mentally ill are prone to violence is a good way to increase stigma surrounding mental illness. Again, although many mental illnesses are statistically rare, many people do experience mental health problems, including depression and anxiety, and are less likely to speak about these things and seek help if we have negative stigmas surrounding them. Additionally, the mentally ill are prone to victimization and are prone to, they're more likely to be hurt by others, and this is in part because of the stigmas we have that they themselves are violent. And finally, when we dismiss certain violent acts as being a result of someone's mental illness, we delegitimize that violent act, and we also remove responsibility from the person who committed it and the responsibility of us as a society. So what I'm talking about here is in the context of mass shooters. Often the media will dismiss, they'll be kind of dismissive of what's going on with a mass shooter by saying, well, he must have had a mental illness, he must have had schizophrenia, somebody has to be crazy to do something like that. And I think we could all agree that people who engage in mass shootings aren't mentally well. However, a good proportion of the mass shooters in recent years have not had diagnosable mental illnesses. Again, we're increasing stigma of those with mental illnesses when we conflate these types of behaviors with mental illness. But not only that, we remove the personal responsibility of these people who committed horrific crimes. On top of that, many of these people, typically young men, were radicalized online. They were able to get guns. So we kind of remove both their personal responsibility and the responsibility of society when we try to claim that it was a single issue that might have caused their behavior, when in fact it is a conflation of issues, one of which can be and often is mental health trouble. So now we'll move into the different types of disorders so that we can begin our conversation about these specific disorders. The first type of disorder are anxiety-related disorders, and this includes generalized anxiety disorder, panic disorders, phobias, PTSD, and obsessive-compulsive disorders, or OCD. Next, we'll move into mood disorders, which include major depressive disorder, bipolar disorder, and suicidality. Then we'll discuss personality and dissociative disorders, which include borderline personality disorder, psychopathic personality disorder, and dissociative identity disorder. Then we'll discuss schizophrenia. And finally, we'll discuss childhood disorders like autism and attention deficit hyperactivity disorder, or ADHD. Here's a chart showing the lifetime prevalence for mental disorders. And if I remember correctly, this was based on data from a study that collected data from a large number of participants. I think one of the studies had over 10,000, and it looks like this chart is from multiple studies. So you can imagine this was this is a large population. And they assessed how many people had been diagnosed with or could meet the criteria for diagnosis of one mental disorder at some point in their lifetime. And what they found is that about 50% of people will experience at least one type of mental disorder or meet the diagnostic criteria for a type of disorder at least once in their lifetime. So this may sound scary, right? I don't think we want to hear that it's likely that we'll experience some sort of mental disorder, but what this means more so is that experiencing difficulties with your mental health is exceedingly normal. And it's of course something that we can always work on improving as a society and as individuals, but that if you're having any sort of struggle, that you're really not alone at all, that you have a large peer group. And you have a peer group to turn to, A, for help, and B, to make you feel as though it's okay to seek help for any sort of disorder that you are experiencing. And specifically, I want to draw your attention, especially as college students during this particularly really scary and troubling time we're going through right now, that this may be exceedingly anxiety provoking, but the disorder that is most prevalent are these kind of are anxiety disorders, right? So if you're having difficulties with your anxiety and managing them, again, that's very normal, and there's help out there if you want to seek it. But you can peruse the rest of this on your own time. So with that said, we'll now move on to our discussion of the first major type of disorder, the anxiety-related disorders. And as we've discussed before in quite a few chapters now, anxiety can be adaptive, right? It's adaptive to feel a little bit of stress about the fact that you have a bill coming up, because that will motivate you to pay it. It's normal and adaptive to feel a little bit of stress or anxiety about saving money. It's normal and adaptive to be a little bit anxious around cliffs, right? Because that's protective. Additionally, anxiety is often transient, right? It's not constant, overbearing. Sometimes you have a little bit of a stressor over a social interaction, or again, about a deadline or a due date. But this is very normal and not kind of intrusive in your life. However, when anxiety is excessive or constant or kind of over the top, or about things that don't really provoke anxiety in other people, this suggests that there's a disorder going on. And now again, as we discussed in the last slide, this is the most prevalent of all mental disorders. 32% of people will fit the criteria for one or more of this type of disorder at some point within their lives. And also, the average age of onset for people to begin experiencing anxiety-related disorders is quite young. It's 11. It's not, post-puberty. It's not during college. It tends to be around 11. That's also when Americans tend to go to middle school. So maybe there's something there, is all I'm going to say about that. So anxiety-related disorders are often preceded by a stressful life event. So death of a family member, career change, these kind of large stressful life events can trigger an anxiety-related disorder. So now I feel bad about making a joke about middle school because it's preceded by events that are larger than, puberty. So the first anxiety disorder we'll talk about is generalized anxiety disorder. And about 2 to 3% of people have generalized anxiety disorder. And this is characterized by continual feelings of worry, anxiety, physical tension, and irritability across many areas of life functioning. So I think when we talk about anxiety disorders, generalized anxiety disorder is the one that kind of comes to mind most. And this is because, this is anxiety when it gets out of control, as this, handy dandy NIH panel shows on the right. This is kind of what we classically think of out of control anxiety, when it's constant feelings of anxiety about things that might not be anxiety provoking to someone else, it impeding actual physical functioning because you're tense all the time. It can also impede your social relationships because you feel more irritable, you're on edge all the time. So this is a quite impactful disorder. Women are more likely to have generalized anxiety disorder than men. And in the US, there's lower risk among Asians, Hispanics, and African Americans when it comes to generalized anxiety disorder. Generalized anxiety disorder is also highly comorbid with substance use disorders. So people who have generalized anxiety disorder, there's also a significant prevalence of substance use disorders. If you remember when we talked about in the consciousness chapter, often substance use disorders can arise out of coping with other stressors, or relying on a substance instead of developing other sorts of coping mechanisms. The next anxiety disorder is a panic disorder. So this is when you have repeated and unexpected panic attacks, along with either persistent concerns about future attacks or a change in personal behavior in an attempt to avoid them. So a panic attack is a brief, intense episode of extreme fear. And it's characterized by sweating, feeling dizzy and lightheaded, having a racing heartbeat, and feelings of impending doom, gloom, death, and feeling as though you're going crazy. And interestingly, these are very similar symptoms as a heart attack, which is not helpful if you're ever having a panic attack, that it'll feel as though you're having a heart attack as well. So, your body is just really betraying you with a panic attack. So a panic attack can be without cause, or it can be triggered by an event. Sometimes people can have panic attacks without necessarily having had a trigger, in part because it's not necessarily, having a panic attack isn't necessarily a rational thing. It is a physiological response that is due to a psychological disorder. And about 20 to 25% of college students have experienced at least one panic attack in their life, or in their lifetime, or even within their college experience. So I'm not sure if any of you have had one, but I'm sure that they are scary and overwhelming. And what is, additionally difficult about a panic disorder is that not only are you having this incredibly stressful experience that is pretty horrifying, but also then in the future, you are then consistently concerned about having another panic attack, and you might go out of your way and negatively impact your life in order to avoid having another one, right? Maybe you stop going out with friends, or you stop going to class. You would negatively impact your life in order to avoid having a panic attack. And then that fear and that anxiety also makes it you more prone to having another panic attack in the future. So it's really, circular, and the panic disorders really build on themselves. Then we have phobias. We've talked about phobias before in the learning chapter. A phobia is an intense fear of an object or situation that's greatly out of proportion to its actual threat. And this is actually the most common of all anxiety disorders. About 1/8 of people have a phobia. So people can be, extraordinarily afraid of animals, right? They can be afraid of spiders or lions and tigers and bears or bees or any sort of other scary animal, or even not a scary animal. Some people can be have a phobia over fluffy kittens. Some people also have phobias with blood. They pass out as soon as they see blood. Thunderstorms. Some people, my dog actually, I know this is a bad comparison. My dog is absolutely terrified of thunderstorms and fireworks, and I have to say I'm very glad she went deaf before July 4th this year. It's sad because she's old, but good because she's not going to be terrified out of her mind every time there's a thunderstorm. But also, so I think people can maybe rationalize, like, okay, some animals are scary, they have big teeth. We've talked about how being afraid of spiders and snakes seems to have some sort of biological mechanism behind it. So these all seem more rational than potentially something like trypophobia. So I'm very sorry to anybody who has trypophobia. That apparently some people feel very afraid and disturbed by looking at an image like this. So I'm sorry to everybody who's, has this, is now forced to stare at it. A lot of people actually experience this kind of fear and discomfort for these types of images. However, of course, this does not present a threat, just like fluffy kittens don't present a threat, and other types of situations don't present a threat that people then have those kind of extreme phobias in response to. One example of a phobia is agoraphobia. So this is the fear of being in a place or situation from which escape is difficult or embarrassing, or in which help is unavailable in the event of a panic attack. So I think sometimes people get agoraphobia confused with social anxiety or fear of being in a crowd. Because people with agoraphobia tend to stay at home, because being in places like crowds or in new places makes them afraid that they won't be able to kind of get out of that situation. And about 1 in 20 people have agoraphobia. And people with panic disorders, right, we just talked about this, end up developing agoraphobic symptoms because they're so afraid of having a panic attack. They end up being, afraid of having one out in public when they can't get help, or not being able to get out of a situation that's about to cause a panic attack. So what I was just describing were specific phobias. These are phobias of objects, places, or situations. So phobias of spiders, phobias of heights, phobias of bubble wrap are all count as specific phobias. Fear of public speaking is also a specific phobia, and a lot of people have a fear of public speaking. However, this is distinct from social anxiety disorder, which is an intense fear of negative evaluation in social settings and nearly all social settings. This anxiety goes well beyond stage fright, which is something, again, that most people experience. So people with social anxiety disorder can feel intense fear while eating in front of people, while walking, to work in front of people. That they have a fear that goes beyond, a specific phobia, and will end up kind of influencing all experiences that happen to have other human beings around, that happen to be in social settings. Now we'll discuss post-traumatic stress disorder. PTSD is marked emotional disturbance after witnessing or experiencing a severely stressful event. So the types of traumatic events that can affect people with PTSD include rape, combat, natural disasters like hurricanes or earthquakes, However, it can also include situations in which people are exposed repeatedly to distressing details of a traumatic event. So it doesn't have to be a single traumatic event. It can be smaller traumatic events, but having to be exposed to them repeatedly over time. And one key characteristic of PTSD is that they are marked by flashbacks. They are marked by kind of returning and having that emotional, terrifying, anxiety-provoking memory kind of return, and it makes people kind of re-feel those feelings of emotional disturbance or, again, fear within the flashback. Other symptoms of PTSD include efforts to avoid thoughts, feelings, places, objects, conversations that remind the person of the event. Somebody who might have, experienced a really scary and traumatic event from, let's say a hurricane, may want to move out of Florida and want to live somewhere where there's fewer kind of disastrous hurricanes because it causes that much fear and anxiety in them. They also have recurrent dreams about the incident, they have increased arousal, and they startle more easily. Additionally, reminders of the incident, right? They attempt to avoid the things that will remind them of the event. So reminders of the incidents can actually cause full-blown panic attacks in people with post-traumatic stress disorder. So PTSD can be difficult to diagnose, in part because some symptoms may have been present before the traumatic event that somebody experienced. So maybe they were prone to panic attacks or had difficulty sleeping or other symptoms of anxiety. And then after a traumatic event, maybe these symptoms worsen. And these symptoms occur in other disorders. So it gets a little difficult to diagnose PTSD as being separate from other types of anxiety disorders like panic disorder, generalized anxiety disorder, or if it is simply a more severe case of those types of disorders. However, post-traumatic stress disorder is its own category of disorder. It can just be difficult for diagnosticians to actually pinpoint whether or not something is PTSD or severe panic disorder or severe generalized anxiety disorder. So now we'll move on to obsessive compulsive disorder. This is a condition marked by repeated and lengthy, so at least 1 hour per day, immersion in obsessions or compulsions or both. So someone can have an obsession or somebody can have just compulsions, or they can have both together. So an obsession is a persistent idea, thought, or urge that is unwanted. And this can cause marked distress. So this can be incredibly stressful for someone to experience this kind of intrusive idea. Then a compulsion is a repetitive behavior or mental act that is performed to reduce stress. So often compulsions can be a repetitive behavior performed to reduce the stress that is brought on by obsessions. So now we will watch a video on obsessive compulsive disorder.
What I would do is basically if I had to touch it to go like that, I would make sure the time was right, and then I'd be like 1, 2, 3, 4, 5, and then like, oh no, like a bone cracked or something, or I'm itchy, so now I gotta do it again. So 1, 2, 3, 4, 5, and now that's 2 times I did it, but 2 is a bad number, so now I gotta do it 3 times, so 1, 2, 3, 4, 5.
Harlan Kirschenbaum describes just one of the rituals that used to rule his life. For 13 years, he lived with an extreme case of obsessive compulsive disorder, or OCD. It's a chronic psychiatric condition that has 2 main symptoms: obsessions, or intrusive unwanted thoughts that can't be pushed away, and compulsions, often called rituals, which are repetitive behaviors done to reduce anxiety.
My 2 obsessions are death and cancer, so I would come up with all these like crazy rituals. Like if I touched a wire, then I would think my brother would get cancer because of it. And everything morphed, and I got more and more rituals as time went on, and every day it seemed like I was adding a couple. I was housebound and I couldn't do anything for myself anymore.
At the height of his illness, Harlan had more than 100 daily rituals and couldn't touch or look at his family members.
I had thoughts like all the time of just like you know, driving into a wall or just anything, because I couldn't do it. It just took all my energy out. Like, I'd be crying in public, and, you know, 30 years old, and I'm sitting there crying because I saw a traffic light, and now I think that I'm gonna give somebody cancer because of it.
Dr. Peggy Richter is head of the Frederick W. Thompson Anxiety Disorder Center at Sunnybrook Health Sciences Center, one of the few specialized centers in Canada dealing with OCD.
There's a threshold at which point we call it a disorder that merits a diagnosis, and that is when the symptoms waste about an hour or more of the day, cause significant distress for the individual, or get in the way of their ability to function.
OCD is extremely common, affecting about 1 in 40 people. And while research is ongoing to fully understand what happens inside the OCD brain, Dr. Richter says it is a treatable condition.
There are two major forms of treatment: cognitive behavior therapy, which is a form of talk therapy, and medication, both of which can be very helpful to the illness. So a good starting point is to see one's family doctor and get a referral to a specialized anxiety treatment center if possible.
Both of these approaches worked for Harlan, but because his OCD was so severe, he also underwent an intensive 3-month inpatient program in the U.S. Harlan says treatment gave him his life back. He can now function without rituals and is able to hug his mother again, something he wasn't able to do for 10 years.
And I grabbed her and I gave her such a hug, and it's like all those thoughts, I beat it. Like, I beat it, and she was crying. I was like laughing, but like a crying laugh, and it was incredible after all those years, and it felt so good.
He now urges others to get the help they need.
You got to be fully committed, or else it won't work. And it's scary, and it's a lot of hard work, and there's lots of up and downs. But once you get there, it's just amazing.
So what I hope that video communicated was that obsessive compulsive disorder is obviously more than simply feeling as though you want things to be neat or in order, or you don't like when things are kind of messed up, or, oh, sometimes I get a little obsessive over things, right? Obsessive compulsive disorder is an incredibly disruptive disorder for people's lives. So it can be quite devastating to have an obsessive, OCD as severe as the man did in the video we just watched. But for your quiz, it will be important to know the difference between an obsession and a compulsion, and to understand the relationship between those two parts of the disorder. So there are some disorders that are related to OCD, one of which is body dysmorphic disorder. This is when someone is preoccupied with an imagined or slight defect in their appearance. So they might believe that their lips are too thin or their ears are too big, and they believe that these slight defects are larger than they really are, and they're preoccupied with this area of their body or their appearance. So 1/3 of those with body dysmorphic disorder also suffer from OCD, which implies that these are highly related, right? So people with body dysmorphic disorder end up having quite a few intrusive thoughts about their perceived, about their slight defects or imagined defects in their appearance. So yeah, these are highly related disorders, which implies that body dysmorphic disorder might be a type of OCD. Tourette's disorder is also related to OCD. Tourette's disorder is marked by repeated automatic behaviors. So things like motor tics, twitching or facial grimacing, or vocal tics like grunting or throat clearing. They say that this is also related to OCD. So how do anxiety disorders manifest? What are their roots? Some parts of an anxiety disorder can be learned. If you remember in our discussion of classical and operant conditioning, little Albert learned to be afraid of fluffy animals because they were repeatedly paired with negative stimuli. So you can learn to be afraid of something after a negative experience or a paired negative experience with that cue that will later make you feel anxious. Additionally, we can develop anxiety or phobias from observation. If you remember, again, in the learning chapter, monkeys could be taught to be afraid of something simply by witnessing another monkey reacting in fear to that object. So if you, I like the example your textbook gives. If you have a dad who's afraid of dogs, when you're a small child, you might not feel any fear toward a dog. But if you witness your dad, kind of jump and scream every time he sees a dog, you'll kind of learn that that's probably something to be afraid of. The next root of anxiety disorders is catastrophizing. So this is when we predict horrible events despite their low probability. So people with anxiety disorders are more likely to predict or feel as though their plane is going to crash when they're flying. They're more likely to predict something like a car crash occurring. Although a plane crash is very low probability, a car crash has higher probability, especially all the scooters around Gainesville. So just be safe, guys. Additionally, people with anxiety disorders who are catastrophizing are more likely to interpret ambiguous stimuli as threatening. So this can even include, ambiguous social interactions, right? Somebody smiles at you, somebody without an anxiety disorder will take it as is, think somebody's smiling at them. Somebody with an anxiety disorder might interpret that as somebody trying to manipulate them or somebody, nefariously smiling at them. So they end up catastrophizing small events or small stimuli into something larger than they are. People with anxiety disorders are also more likely to be higher in anxiety sensitivity, so they have a greater fear of feeling anxiety. Again, this kind of goes back to the idea of, phobias or panic disorders, that if you experience anxiety, that's, those are scary and difficult and distressing emotions. So you end up being afraid of feeling that fear again, feeling those anxiety-related symptoms before you're actually introduced into a situation where you might actually, one of those anxiety-related symptoms is triggered. So you end up feeling anxious all the time, either in situations that make you anxious or when you are afraid of being anxious. There are biological influences on anxiety disorders. We don't totally have a great understanding of anxiety disorders as of now. We have some understanding, but it's not totally fleshed out when it comes to biological influences. We do know that many anxiety-related disorders are genetically influenced, and if you remember from the last chapter, genes do seem to influence people's level of neuroticism, and neuroticism is highly related to anxiety disorders. So genetically, it doesn't actually seem as though those with generalized anxiety disorders are distinguishable from those with major depression. And this is one of the reasons that people suggest that these two disorders are so highly comorbid, that they may be, they may just be kind of different manifestations of the same biological dysfunction. However, although we might not be able to see specifically distinctions between anxiety disorders and mood disorders or major depressive disorder, that doesn't mean that there might be more biological distinctions between the two that we just haven't really been able to parse out yet. This does seem to be why, the fact that these two are so genetically close is probably why they're highly comorbid. But again, the science is a little bit limited on exactly understanding the distinction between these two disorders. So now we'll move into our discussion on mood disorders. Mood disorders are characterized by extreme moods and emotions, and about 20% of Americans will experience a mood disorder or symptoms of a mood disorder at some point in their life. And mood disorders can develop at any point. Mood disorders tend to be chronic and tend to be worse if they develop early. Additionally, mood disorders are more prevalent in women than they are in men. So mood disorders can be characterized both by extreme sadness, but they can also be characterized by extreme elation. So it's not just extreme negative moods that we're going to talk about. We'll also talk about extreme, people who might experience extreme positive moods within the mood disorder section. So major depressive disorder is characterized by people who experience sort of major depressive episodes or chronic major depressive episodes. And this is most likely to occur in people in their 30s, right? This isn't a disorder that's tends to pop up when people are in adolescence. And women are twice as likely to experience depression at some point in their lives as men are. So a major depressive episode is a state in which a person experiences a lingering depressed mood or diminished interest in pleasurable activities, along with symptoms that include weight loss and sleep difficulties. So depression is characterized by both or either feeling depressed and down and sad, and that kind of extreme hopelessness and all of these negative emotions. But it's also characterized by sometimes extreme apathy, so not feeling emotions or reactions to things that might have brought you joy in the past. Typically, major depressive episodes, there is a gradual development into a major depressive episode, and they tend to be long lasting. They last about 6 to 12 months, and they're often recurrent for people. Some major depressive episodes can be chronic. They can last decades in people's lives. Of course, they can also be spurred by stressful life events. The death of a loved one can bring about a major depressive disorder, and it can also influence, it can also kind of create a chronic major depressive disorder within someone. They can end up having chronic major depressive episodes after an event like the death of a loved one. Things like loss of a job, a change in career, these are all things that can kind of trigger a depressive episode. In this slide, we'll review some explanations for major depressive disorder, and we'll review explanations of major depressive disorder from multiple theoretical perspectives. And each of these theoretical perspectives provides an explanation for major depressive disorder that has evidence to support it. And however, each one of these explanations also does not really seem to provide the full explanation for why major depressive disorder occurs in people. So what this tells us isn't that one explanation is best or that one explanation is wrong. What it tells us instead is that each of these explanations makes up some part of why major depressive disorder occurs, because major depressive disorder is a complex interplay of biological, psychological, and social influences. So we'll start with the behavioral model. The behavioral model is that people become depressed when there is a lack of positive reinforcement in their lives. So when they go out to meet friends, maybe they don't have a positive experience, or maybe if they stop having positive stimuli in their life, and that makes people want to withdraw and give up. If you stop having positive reinforcement for your behavior, you're less likely to engage in any behavior. And behavior, of course, includes feeling certain emotions. So feeling happy when you don't really ever get any sort of positive reinforcement for that emotion means that you're going to have that emotion less. So the behavioral model kind of centers around the idea that people with MDD stopped having as much positive reinforcement in their life. The next model is the interpersonal model. And this is less about why somebody might start to become depressed and more why depression can, slight depression can kind of turn into major depression. And this is that when people start to feel depressed, they need excessive reassurance from others. As people start to feel down, that's when they need other people more, and they become a little bit more self-centered too, in a way, according to the interpersonal model, that they want support from others and they reach out and they want to kind of take support from other people. And because they're seeking excessive reassurance from others, others might pull away. It's not necessarily typical behavior, so others might begin to dislike and reject them, which just increases those feelings of depression and increases those feelings of abandonment and loneliness and hopelessness. So it's not that somebody with depression is really being, annoying, but they may be engaging in behaviors that are a little bit harder to get along with, and might end up creating neglect and rejection, which can, of course, create more negative feelings. Then there's the cognitive model. In this model, the explanation for major depressive disorder is more about the fact that people with depression begin to have negative beliefs about the world and negative beliefs and expectations about themselves and also the future. So it's less that the world actually begins to be more negative, and more that people kind of get into a negative mindset in which they can't necessarily see the positives. And also, there is evidence that this is something that occurs with people who are depressed, that they do tend to take on these negative beliefs. They also begin to take on static negative beliefs. So instead of believing that, they're going through a tough time right now, they believe that they will be going through a tough time forever. Again, that's the idea of having a negative perspective of the future. They also have, instead of, if you've ever made a mistake in class, or if you've ever had a little bit of a social flub, somebody without depression might be able to shake that off and just feel a little bit embarrassed. But somebody with depression has kind of a static negative belief about themselves and might turn that into, oh my God, I made that mistake because I'm just an idiot, nobody will love. And they'll turn what is a benign interaction into kind of a spiraling negative perspective of themselves, and it can reinforce their own negative beliefs about themselves. So the cognitive model is really about these thoughts and beliefs and interpretations of the world. Next is the learned helplessness model. And this came from a study where, a little bit upsetting as far as studies go, where the researcher found that if you chained a dog to the ground and then shocked them, they found that even if you didn't chain them again and shocked them the next time, they wouldn't try to run away, that they had learned that they could not escape the pain, and they'd learned how to be helpless. And what they found is that there is a little bit of learned helplessness among those with depression, that when things are going wrong in their life, or when things have started to become more negative, they will tend to feel more helpless, while someone without major depressive disorder, or somebody who doesn't necessarily have kind of a learned helplessness perspective, is more likely to feel as though they have an impact on the world and they can change their situation, while someone who is prone to major depressive disorder, or who already has major depressive disorder, feels much more helpless in the face of the events that they can't control. The next explanation for major depressive disorder comes from the biological model. And what we found is that it seems as though MDD is heritable. It does seem to be tied to genetics, and specifically, genes may actually affect levels of serotonin and dopamine, and levels of serotonin and dopamine reuptake, two of which are these are neurotransmitters that impact pleasure and reward systems. So somebody with major depressive disorder may actually, not be able to feel the same amount of pleasure or reward from, typical stimuli within your environment that somebody without major depressive disorder would feel. So somebody with major depressive disorder might not be able to enjoy their favorite meal in the same way, because there's more reuptake of their neurotransmitters that are responsible for feeling the pleasure and feeling the reward of that favorite meal. So again, what you'll notice is that for each of these, there is evidence for them, and each of them seem to explain part of the complex interactions of major depressive disorder. There is evidence that people with depression, their behavior changes with other people. They begin to seek excessive reassurance, and that makes people more likely to pull away at a time when somebody needs more help. We know that people with major depressive disorder have negative beliefs, and that these negative beliefs are more likely to kind of keep them in a cycle of negative beliefs, and keep them believing that they won't ever be able to get out of the kind of negative place that they're in. And again, we have a lot of evidence for the biological model of major depressive disorder as well. So each one of these provides at least some explanation for major depressive disorder. And, there's more happening in the biological field every day to more fully explain exactly what's going on with major depressive disorder. Now we will move into a discussion of bipolar disorder. So to clear up a little bit of confusion about bipolar disorder that I've heard before, bipolar disorder is not moodiness. Bipolar disorder is not characterized by people who might swing from one mood to another, or who might be happy in the morning but sad and cranky at the end of the day, right? That's not really what bipolar disorder is. Instead, bipolar disorder has a more specific definition than that. Bipolar disorder is a condition marked by a history of at least one manic episode. And in the past, it actually used to be referred to as manic depressive disorder. So a manic episode, which we've touched on earlier in this lecture, is an experience that's marked by dramatically elevated mood, decreased need for sleep, so feeling more energy, inflated self-esteem, feeling better about oneself, increased talkativeness, and also, importantly, irresponsible behavior. So in contrast to major depressive disorder, bipolar disorder is as common in men as it is in women. And often a manic episode is either preceded or followed by a depressive episode. So people will have these, extreme highs, but then they will also have experiences with depression in a similar way that we'd see in something like major depressive disorder. They'd have similar symptoms of listlessness, hopelessness, lethargy, apathy, etc. And importantly, episodes can be separated by years, or they can follow one another rapidly. So many people with bipolar disorder live their lives without having frequent episodes. Again, it's not for a large proportion of people with bipolar disorder, they're not constantly swinging between two poles, right? Sometimes they can be separated by years. With that said, if somebody's had one episode, they are significantly more likely to have another. Can that make sense? So manic episodes can cause serious problems in people's lives despite the feelings of, extreme elation. So manic episodes are associated with reckless drug use, so even starting and trying drugs they hadn't tried before, reckless sexual behavior, and destruction of interpersonal relationships, right? Reckless sexual behavior can destroy a relationship somebody might have had. If they're in a committed, serious relationship, and then they go through a manic episode, they may do some things that they wouldn't do when they were, when they weren't going through a manic episode. They can have uncontrolled spending sprees, right? That suddenly shopping is an incredible amount of fun and it feels amazing and you feel great about yourself, so clothes look amazing. And they can put themselves into serious debt. So a manic episode is marked by extreme elation. And even if the manic episode is short, people can do things within these manic episodes that have serious long-term consequences on their lives. So in a conversation about mood disorders and, especially after discussing major depressive disorder and, depression associated with bipolar disorder, it's also important to take a moment to think about suicide. And I'm not an expert. I am not a counselor by training. So for this section, I'll probably just give the, based on the information based on the textbook. And there'll be more resources at the end of the PowerPoint as well. But it's important to know the major risk factors of suicide, especially if you are trying to maybe look after yourself and also look after loved ones, right? That some of these risk factors may be important to know in case you have a loved one who's going through something similar. Major risk factors of a completed suicide, of course, include previous attempts. People who have already attempted suicide are more likely to have a completed suicide at one time. So somebody who has had a previous attempt at suicide, they're not somebody who is just crying out, it's not for attention, right? Previous attempt at suicide is incredibly, incredibly serious and should be taken seriously and should be treated with concern. Depression is, of course, another major factor. Feelings of hopelessness and feelings of intense agitation. Things like substance abuse and schizophrenia are associated with suicide. The people within the LGBTQ community also commit suicide at higher rates than cis hetero people, but a lot of this has to do with social stigma, right? That feeling isolated and bullied, and factors like that are more at work here. Additionally, losing your job, having a chronic, painful, or disfiguring physical illness. And this is another one where people with disfiguring physical illnesses or disabilities are often treated as though their life doesn't matter as much as everybody else's does. So again, stigma is really important here, because stigma can influence how people feel about themselves and make them more prone to suicide. Additionally, of course, grief is a huge component of suicide. The recent loss of a loved one makes somebody more likely to commit suicide. So if you know someone who's lost someone recently, it's important to reach out and to be there for them. Family history of suicide. It does seem as though, right, major depressive disorder is closely related to genetics, and unfortunately, suicide is related to severe depression. So especially if people have lost their loved ones through suicide, it makes members of a family more likely to commit suicide as well. Other mental disorders, including personality disorders and anxiety disorders, and old age. Old men actually have the highest completed suicide rates, in part for older men. There's a lot of loneliness. A lot of loneliness, brings about those feelings of intense depression. And unfortunately, old men tend towards, feeling more of those, types of loneliness, especially widowers. Recent discharge from a hospital is also a risk factor for suicide. Again, it's important to be aware of the risk factors for suicide, both for yourself and for others. Again, you might not feel as though, you'll ever really get to that place, but depression and suicidal ideation are not abnormal, right? A lot of people go through those feelings, and that isolation of feeling as though, you're not normal, you're going through something totally unique, can make you feel more isolated and make you more prone to withdrawing. But also knowing the risk factors, for yourself means that if you go through, if you're experiencing depression or you've recently lost a loved one, it's really important to reach out for help in order to kind of reduce suicide. So there's some additional information, additional statistics. About 40,000 people commit suicide each year. And of course, this is a number that's really important to try our best to reduce. And for every suicide, there's an estimated 8 to 25 attempts. Again, people who commit suicide have often tried before, and those attempts weren't for attention. Those were real attempts from a person in deep pain. So again, somebody who's already attempted suicide once is somebody to kind of provide additional care for, or to be considerate of in that way. Additionally, something sort of surprising but really, really, really important for people to know is that those who are coming out of a severe depression are at heightened risk. So people who, sometimes people who are severely depressed can be almost catatonic. And some people have reported that their loved ones who have committed suicide, they were catatonic, hopeless, listless for, months, and then had a day when they were more excited, seemed more hopeful, seemed happier, finally got out of bed, finally showered, etc. But unfortunately, this can put people at additional risk because they ultimately end up having more energy to complete the task. They also, sometimes the finally seeming hopeful is because they've made the decision to commit suicide. So if you know someone who's in a severe depression and one day they seem, you know, finally determined, even if it's in a positive way, again, that's something to kind of be mindful of and to be there for your loved one or even an acquaintance. And again, at the end of this PowerPoint, I'll have some kind of local resources or people you can call if you are ever feeling like you need to talk. Now we'll move into a discussion of personality disorders. Personality disorders are characterized by personality traits that are inflexible, stable, and expressed in a wide variety of situations and can lead to distress or impairment. And these personality traits appear first in adolescence, or at least they tend to. The first personality disorder we'll discuss is borderline personality disorder, which is a condition marked by extreme instability in mood, identity, and impulse control. People with BPD have extreme shifts in, you know, the life goals they have for themselves, their own interests, and in their own identity. They even, you know, the way they feel about themselves can shift very quickly. Additionally, borderline personality disorder is marked by unstable relationships because their relationships tend to alternate between extremes. They'll go from worshiping someone and love bombing them and being obsessed with someone to hating them the next. And this is, you know, in part due to people's who have BPD having intense fear of abandonment. So they'll go from, you know, extremely loving someone to, you know, being angry with them because of perceived slights and perceived abandonment because of their extreme fear of not having that relationship. Borderline personality disorder can be characterized by what we can call stable instability. It is characterized by consistent instability in almost all aspects of life. So the personality of a person with borderline personality disorder is that unstable or unstable personality. The symptoms of BPD include drug use, sexual promiscuity, overeating, self-mutilation, threatening or attempting suicide, and experiencing intense feelings of abandonment. Again, they may jump from one unhealthy relationship to another. You know, they love someone, they're their everything, they couldn't be anything without this other person, and 3 months later they hate them and they've jumped onto a new person who they love and who's their everything. And so that, you know, those intense feelings of abandonment and those extreme relationships are a characteristic of BPD. So BPD is unfortunately one of the most stigmatized mental illnesses, and in fact, some counselors refuse to see patients with BPD because they believe that they're treatment resistant. This is, of course, part of the stigma that even exists within, you know, trained counselors. And this is in part because of how important interpersonal relationships are to people with BPD. Some people with BPD can be manipulative, and it's a stereotype that all people with BPD are manipulative, but it's one of the characteristics that we end up associating with those with BPD, that they may lie to kind of curry favor. So people who treat those with BPD can sometimes struggle with, you know, disentangling truth from fiction and understanding when they themselves might be being manipulated, and thus they refuse to treat people. However, because somebody is potentially manipulating you or is more resistant to treatment than potentially another person with a different type of mental illness, this does not indicate that they are any less worthy of treatment. So I think that if somebody is unwilling to treat a person with BPD, it has less to do with people with borderline personality disorder and more to do with a lack of training by the counselor. There are a few explanations for why BPD might present itself in people or why it may exist. The first is Kernberg's model, and this models based on the idea that somebody may have issues in childhood and adolescence with developing their own sense of self and with bonding with other people. So they end up having difficulty integrating differing perceptions of people. So they begin to believe that people are either all good or all bad, or experiences are all good or all bad. So for somebody who doesn't have BPD, they might be able, you might be able to interact with a person and have a positive experience with them. And then if you have a negative experience later, you can integrate the two and maybe kind of come to a conclusion that this person is in the gray area, or you're able to, think of rationale for why they were negative, or maybe even rationale for why they were positive, right? That we can integrate multiple experiences with a person or with an experience to understand that it comes together as a whole rather than one experience or one action defining a person. So for somebody with BPD, however, when they're with somebody and things are going well, they don't have a problem perceiving that person as wonderful and amazing. But if one thing goes wrong, if there's a perceived slight or a negative experience, that might then characterize their experience with that person as all bad. And then they begin to lash out and, be often mean to the person who they now have decided is bad instead of good. When in reality, of course, people are more complex than that. There's also the sociobiological model. This is that people with BPD inherit a tendency to overreact to stress and experience difficulties with regulating their emotions. Again, that's marked by extreme instability in emotions and self-concept. And interestingly, twin studies do suggest that BPD traits are highly heritable. It is, in fact, one of the most heritable mental disorders. So this indicates to us that bipolar disorder is really tied to our genetics, and it does seem as though that kind of overreaction to stress and emotion regulation would be a key part of that genetic, a genetic cause. The next explanation for bipolar disorder is the emotional cascade model. So this is that people with BPD may intensely ruminate about negative events or emotional experiences, and that this can result in an emotional cascade. So rumination about negative events is quite normal. It is also more prevalent in people with anxiety and depression than perhaps people who are, for lack of a better word, typical, or who are not experiencing a mental disorder. However, for a person with bipolar disorder, they may have then an emotional cascade that comes about after ruminating on a negative event. These emotional cascades can include impulsive self-injurious actions, right? They can cut themselves, they can bang their head against a wall, they can really hurt themselves, and they do this to distract from their negative ruminations. But this can then fuel further bouts of rumination. And of course, another self-injurious action includes not just, physical, but emotional. Lashing out to people who you love is also self-injurious, just not physically. But that these actions will then fuel further bouts of rumination, and thus you have a cycle of emotion regulation issues. Instead of ruminating and being able to pull yourself out of it, or ruminating and kind of staying at that same place, they end up kind of having emotional cascades and kind of go to an extreme version of dangerous place when they're experiencing this emotional cascade. Now we'll discuss psychopathic personality. So psychopathic personality is a condition marked by superficial charm, dishonestness, manipulativeness, self-centeredness, and risk-taking. And people often also characterize it as a lack of empathy for other people. However, it's important here to note that I think psychopathy is one of the mental disorders that I see a lot of, it's not well understood, but there's a lot of, kind of bad pop psychology out in the world. I can think of Dexter as being kind of a really horrible depiction of somebody with psychopathic personality, being a psychopath does not mean that you feel no emotions whatsoever. Many psychopaths feel things like shame or anger, or there's still an ego there. However, empathy does seem to be impaired, in part because this condition is marked by self-centeredness. This is not technically, or it's not really considered a psych disorder within the DSM-5. Instead, they include antisocial personality disorder, which can be similar to psychopathic personality disorder. APSD is marked by a lengthy history of irresponsible or illegal actions. And it's important here to note that being antisocial doesn't mean that you're an introvert who doesn't like to talk to people. Antisocial personality disorder is more, a better way to kind of remember the term is to think of anti-society, because it's more marked by a history of kind of illegal actions and crime and things of that nature. So psychopathy is better researched than APSD, even though APSD is in the DSM-5, so that's what your textbook wants us to discuss instead. Psychopathic personality is part of the dark triad. So people who score highly on this dark triad of kind of personality types are more likely to commit crimes, cause social distress, and cause problems within an organization. So the dark triad is a kind of fruitful area of study because it can provide information about criminal behavior, criminal activity, but also how to have a functioning organization. The three components of the dark triad include narcissism, which is characterized by grandiosity, pride, egotism, and lack of empathy. Machiavellianism is characterized by manipulation and exploitation of others, and a cynical disregard for morality and focus on self-interest and deception, of course, based on, Machiavelli himself. Then psychopathy. So this is characterized by continuing antisocial behavior, right? Likelihood to commit crimes, irresponsible and illegal actions, impulsivity, selfishness, callousness, and remorselessness. That's important. Like a lack of guilt is important with psychopathy. So there are some people who have this kind of dark triad of traits, and these traits end up being kind of highly correlated with one another to in people who are likely to commit crimes and cause distress, etc. People with psychopathic personality are also low in agreeableness and conscientiousness, which would make sense given everything we've just kind of read, right? They are low on how much they want to, be kind to other people, and low on responsibility. So people with psychopathic personality disorder are majority male, and adults with psychopathic personalities exhibited similar personality traits as children. So they were more likely as children to have callous and unemotional traits or emotional coldness, and generally a lack of guilt and empathy. However, with that said, some children do seem to grow out of these traits. If you know a child who doesn't feel guilt or empathy or any sort of emotional warmness, they may still grow out of those traits, but they are more likely than a child without these traits to end up having psychopathic personality disorder. So interestingly, and this is a fact I actually see shared quite a bit, people with psychopathic personality disorder aren't simply criminals, even though they are more likely to engage in crime than somebody without psychopathic personality disorder. But psychopathy is also more represented in positions of leadership than it is in other sorts of positions. So I don't actually have the incidence rate on hand right now, but if the incidence rate of psychopathy in the general population is 0.1%, in positions of leadership like politicians or doctors or positions like that, or CEOs, the incidence rate is more likely to be 0.5%. So sometimes when we say, I've seen this spread and people are like, I knew it, every CEO is a psychopath and every politician is a psychopath too. And the incidence rate of psychopathy is pretty low. It's just more represented in positions of leadership statistically than it is in kind of the gen pop. And this is because something like fearless dominance, right, not feeling fear or empathy and wanting to dominate others, is something we associate oddly with leadership, right? You have to be willing to climb to the top. You have to have superficial likability, right? This is marked by superficial charm. You have to be ruthless. You have to not care about others that you might be screwing over in the process of getting to the top. And you have to be willing to take risks. So these are things that are helpful when it comes to rising to the top of certain organizations, right? This is something that helps people rise, can help people rise to the top of a job or to the top of a political career. And then again, lots of medical, people in the medical field end up having, not lots of, but more people in the medical field end up having psychopathic personality traits, in part because the medical field requires a lot of empathy, but that can be very difficult when you are dealing with people who are dying and sick and injured. So somebody with less empathy can find some aspects of the job of being in the medical world easier. With that said, I think statistically they probably make worse doctors without empathy, but that's a discussion for another day. So psychopathy is really, we don't really know much about it. We don't know why psychopathy presents itself. There's some theories, but there's still a ways to go to more fully understand this condition. One kind of hypothesis for why psychopathy may exist is that it seems as though individuals with psychopathy don't show the same reactions to unpleasant, unconditioned stimuli. So something like being shocked. So somebody without psychopathy who's shocked may feel a lot of pain and respond and feel a high level of arousal upon being shocked. But those with psychopathy will show lower levels of arousal. So it's almost like they need more stimulation than a kind of typical or non-psychopathic person to feel the same level of arousal. So stimulation may be part of psychopathy. Additionally, those with psychopathy may have underactive amygdalas, which, if you remember from chapter 3, suggest that they might feel less fear than a person without psychopathy. And this is where the Yerkes-Dodson law comes into play. And it's important in this kind of consideration of less fear and less arousal, in that there's an inverted U-shaped relationship between arousal and mood and performance. So people who are low on arousal may end up seeking greater stimuli. Again, this may be why those with psychopathy may be more prone to risk-taking. Additionally, negative stimuli is also not as arousing for those with psychopathy. So something like guilt at hurting others might not be as painful as it is for somebody without psychopathy, right? However, we have an idea of maybe why people with psychopathy are more likely to take risks, but the understanding of the empathy part of it or the self-centeredness part of it isn't totally clear just yet. So still lots of research to go in order to fully understand this particular mental disorder. So now we'll discuss dissociative disorders. And dissociative disorders are marked by disruptions in consciousness, memory, identity, or perception. And dissociative disorders are fairly controversial in the field of psychology, in part because there are still debates about the validity of some of these disorders. And there's more skepticism around some of these disorders than others. Basically, the idea of extraordinary claims require extraordinary evidence is brought up a lot in terms when we're discussing dissociative disorders. The first dissociative disorder is depersonalization or derealization disorder. This is a condition marked by multiple episodes of depersonalization. So feeling as though you're detached from yourself, watching yourself from the perspective of an outsider, or watching yourself from outside of your own body. Or derealization, so the sudden feeling that the world is strange or unreal. So most adults have actually experienced some, at least an episode of depersonalization or derealization. And it seems as though sleep and potentially drug use can influences people's, tendency to have an episode of depersonalization or derealization, right? If somebody has done an hallucinogenic, they may be more likely to have an experience like this. So scientists currently believe, or researchers currently believe, that sleep disorders may play an important role here, and that sleep disorders may have more to do with the disorder than it being kind of totally independent from sleep. So what we've seen is that people who are sleep deprived are significantly more likely to have an incident of depersonalization or derealization. So a sleep disorder may ultimately cause people to almost be walking around in a dream-like state, which can make the world feel strange or unreal. The next associative disorder is dissociative amnesia, and this is when someone is unable to recall important personal information, and this is most often brought up by stressful experiences, so things that can't be explained by ordinary forgetfulness. So where this is seen is in children with significant, adults who experience significant abuse as children, and they'll have large gaps in their memory surrounding those incidences, so those stressful experiences. However, dissociative amnesia is very controversial, in part because it seems as though there may be alternative explanations for why someone may not remember an important or a stressful event. The first alternative explanation is that people have large gaps in their memory anyway, so having a large gap in your memory, especially from childhood, despite the fact that it was stressful, may just be a part of normal forgetting that most people go through. Additionally, another idea is that there's a little bit of motivated forgetting that may be happening around stressful experiences. People don't want to necessarily think of experiences that make them emotional or feel stressed. So instead of it being an actual dissociative, you're disassociating from yourself during this experience, might have more to do with the fact that we are, our memory is constructed all the time. And if we're not returning to and constructing that memory, it's less likely to kind of be A, brought out of storage, and B, remain in storage. So the studies on dissociative amnesia have generally found that all incidents that have been kind of reported in research have been able to be explained away by these alternative explanations, whether somebody had brain injury or, there was motivated forgetting, someone didn't want to think about a particularly stressful event rather than the kind of a dissociative episode surrounding a stressful experience. And again, normal forgetting is also a part of, could have been an alternative explanation as well. Next, a dissociative disorder that's related is a dissociative fugue. So this is sudden unexpected travel away from home or the workplace, accompanied by amnesia for significant life event. So the most prevalent example of this in pop culture in recent years, although we're now quite a few years away from this, in Breaking Bad, I think in the first or second season, one of the characters fakes a dissociative fugue basically to cover up something else he was doing. And unfortunately, that seems to be one of the controversies surrounding dissociative fugues, is that at times people may be kind of running away from their responsibilities rather than a dissociative fugue actually taking place. With that said, there do seem to be also people with significant, where this does happen. However, again, we run into the same problem where we aren't totally able to remove something like head injury from the equation in these other circumstances. So for both dissociative amnesia and dissociative fugue, there may be more, there may be alternative explanations than real psychological events. Now we'll go to the most controversial dissociative disorder, and this is dissociative identity disorder. This is a condition characterized by the presence of 2 or more distinct personality states. So again, we're throwing it back here now. There was a show, I think this one, what's her face, an Emmy. She's a fantastic actress. But there's a show called United States of Tara, and it featured a main character with dissociative identity disorder where she had multiple alternate personalities, and each of these were distinct from her host personality. So again, it's controversial for quite a few reasons, in part because we don't actually know if this is a real disorder. There doesn't seem to be evidence of memory differences across alters. So if one alternate personality learns something, all alternate personalities learn something, which indicates that there aren't truly multiple identities appearing. However, it does seem as though dissociative identity disorder may arise from early severe trauma and abuse, which might lead individuals to compartmentalize their identity into distinct alters. So as of right now, more research is necessary. Again, it's likely that there aren't truly alternate kind of people within one person, because it does seem as though they are able to track memories across identities. However, there does seem to be a specific phenomenon where people will develop multiple kind of identities for themselves. And this is kind of where we need more research to fully understand what exactly is taking place. So now we'll discuss schizophrenia, which we're not including with the other types of disorders, in part because so little is really known or understood about schizophrenia. So we can kind of think of schizophrenia as one of the more severe disorders and also one of the least understood. So schizophrenia is the severe disorder of thought and emotion associated with a loss of contact with reality. And it severely impacts people's ability to lead a normal life, right? It's very difficult to cope with schizophrenia. It's difficult to hold a job or maintain close relationships. And there are some statistics here which will probably be informative, that only about 0.4 to 0.7% of people within the general population have schizophrenia. However, more than 10% of homeless people, or up to as high as 45%, qualify for an actual diagnosis of schizophrenia. Even though the percentage of people in the general population is so low, people with schizophrenia make up half of the people within state and county mental institutions. So that gives you a good idea of how impactful this is for people's lives. With the other disorders, generally people can can maintain jobs, can maintain close relationships, but people with schizophrenia often see severe disruptions to their life. There are, however, some treatments available so that people can be high functioning, but sometimes costs are prohibitive with really any sort of treatment, right? Costs are prohibitive in the United States. But we are starting to learn a little bit more about how to actually treat schizophrenia. So what are the symptoms of schizophrenia? First are psychotic symptoms. So these are psychological problems that reflect serious distortions in reality. So there's a few different psychotic symptoms, and the first is a delusion. So this is a strongly held fixed belief that has no basis in reality. For example, people with schizophrenia may believe that one is being pursued by the government, or they may believe that they are a god, right? One is significantly more negative than the other, right? Or you might believe that a god is speaking to you. So this is a strongly held fixed belief that doesn't actually have a basis in reality. Next are hallucinations. So these are sensory perceptions that occur in the absence of external stimulus. So they may see, hear, or smell things that aren't actually there. And interestingly, the most common schizophrenia symptoms are auditory, right, hearing things, then visual, and finally you can also smell and taste things that aren't actually there. Some more symptoms of psychosis: disorganized speech, so skipping from topic to topic, right, not really having a clear thread of conversation, and associations between the actual words are weekend. So I am forming a sentence, and generally you can follow the sentence because the words make sense together. But somebody with schizophrenia, the kind of meanings and links between words end up being weakened. So they're, when you're listening to them, it might be hard because they kind of stop making sense. Then there's disorganized behavior. So self-care, personal hygiene, and motivation deteriorate, and they can wear clothing inappropriate for the season. So we're in Florida, but I'm from Pennsylvania, and I've spent a lot of time in Philadelphia. And in the middle of summer, you'll see people wearing full winter jackets. Or in the middle of winter, you see people in a tank top and shorts, and often, these are people who are homeless on the street who are probably experiencing symptoms of schizophrenia. In part, this might also be because of disassociations from reality, right? In reality, it's cold, but what the person is experiencing might not actually be feeling that it's winter. Then there are catatonic symptoms. They're actually motor problems associated with psychosis, where people might end up holding their body in bizarre or rigid positions, or they may begin to pace aimlessly. So there are actual physical symptoms associated with psychosis as well. Now we'll discuss some explanations for schizophrenia. Again, keeping in mind that there is very little known about schizophrenia. It seems as though, families don't cause schizophrenia. Having parents who maybe weren't the best parents don't create schizophrenia in their child. However, with that said, for somebody who has schizophrenia, their family members can actually influence the incidence of relapse. And specifically, families with high expressed emotions, so how much they criticize or are hostile or over-involved, can increase the rate of relapse after release from a hospital. However, with that said, this does seem to be highly cultural. Relapse does seem to be influenced by families in most cultures, but how families actually influence rates of relapse is dependent on social norms. So again, in the US, which is highly individualistic, if criticism is very individualized, so high rates of criticism significantly impact and make somebody more likely to relapse. But in countries that are a little bit more communal or more collectivistic, criticism seems less likely to influence rate of relapse. However, lack of family warmth, so families not kind of taking you in and feeling and comforting you and being there for you, that does seem to be highly related to rates of relapse. So families are associated with relapse, but they aren't associated with causing schizophrenia. But the actual way that families influence relapse does seem to be based on social norms of kind of how a family should be or act. Schizophrenia is also associated with brain abnormalities. So those with schizophrenia seem to have enlarged ventricles in their brain. And there's evidence suggesting that it's not necessarily the enlarged ventricles themselves that are causing schizophrenia, but instead that other brain areas may be shrinking or deteriorating. And thus the other ventricles in their brain begin to expand into that space left by the other brain areas. So this suggests that brain schizophrenia has to do with deterioration or loss of volume from specific brain areas. Again, though, more research is necessary to fully understand whether or not it's the kind of expansion of ventricles or the enlargement of ventricles, or if it does have to do with kind of the shrinkage or deterioration of certain brain areas. Additionally, people with schizophrenia have less active frontal lobes during certain mental tasks. than those without schizophrenia. So they experience hypofrontality. However, it's unclear if it's that lower activity within kind of our frontal lobe and in our like executive control areas is what's causing schizophrenia, or people with schizophrenia concentrate less than people without schizophrenia, right? They are, they aren't necessarily fully in realities. They may be concentrating on other stimuli, whether or not that stimuli is real. Additionally, those with schizophrenia, we haven't necessarily ruled out that the activity in their frontal lobes has to do with maybe their diet or smoking, drinking habits, drug use, etc. Schizophrenia is associated with drug use, and drug use also has significant impacts on the brain and significant impacts on executive functioning, which takes place within the frontal lobe. Another biological explanation for schizophrenia involves the neurotransmitter dopamine. And it's believed that people with schizophrenia may either have an excess of dopamine, or they may have abnormalities in their dopamine receptors, that their receptors may take on too much dopamine compared to a typical receptor. And the evidence for this comes from two places. The first is that anti-schizophrenic drugs, or medications that are designed to kind of lower the symptoms of schizophrenia, how they work is they actually block the dopamine receptor sites. So they block the actual uptake of dopamine, so that dopamine has kind of less of an influence within the brain. Additionally, amphetamine blocks the reuptake of dopamine, right? So that means that, if you remember from chapter 3, so by blocking the reuptake of dopamine, the presynaptic neuron doesn't kind of take the dopamine back up, and instead it stays within the between the two, and then the postsynaptic neuron is more likely to take on additional dopamine and then send on more of that signal to synapses down the line. Again, just indicating that there's more dopamine kind of flooding the system and being sent as a signal than you would see in a typical person. So these provide strong evidence that dopamine at least plays some sort of significant role in schizophrenia. There are also significant genetic influences with schizophrenia. There's a chart in your book of kind of the family relationships of schizophrenia, but you won't need to know the actual percentages. But being the offspring of somebody with schizophrenia significantly increases your chances of having schizophrenia yourself. And having two parents with schizophrenia means that their offspring will has about a 50% chance of having schizophrenia themselves. Additionally, what they found is that if you correlate, schizophrenia among identical twins, there's about an 80% correlation there, which tells us that schizophrenia is really tied, again, to genetics. And there's some evidence that schizophrenia might have to do with the gene C4, which is associated with the immune system and the pruning and reduction of synapses. So again, like we discussed in the last slide, there's the potential that because of the variant of this gene, that maybe there's kind of over pruning and synapse reduction going on within the brain, which may be leading to some of the erratic and irrational behaviors. And this might be, again, we see brain deterioration with those with schizophrenia. However, it doesn't seem as though the gene C4 provides the full explanation of schizophrenia, but it does seem to be an important gene within the presentation of schizophrenia. But not everybody with schizophrenia actually has this variant of the gene. So again, still more work to be done. The final explanation for schizophrenia that we'll discuss is something that can also be applied to a lot of the disorders that we discussed today. And this is the diathesis stress model, which is a perspective proposing that mental disorders are a joint product of a genetic vulnerability, or a diathesis, and stressors that may trigger this vulnerability. It's been suggested that up to 10% of the population has or could have a genetic predisposition to schizophrenia. So for example, my great uncle is schizophrenic, so it's more likely that somebody in my family, or me myself, might have a gene that makes me predisposed to schizophrenia, or another member of my family might have a gene and maybe more predisposed to schizophrenia. However, obviously, as we saw in the last couple of slides, clearly 10% of the population is not showing schizophrenic symptoms. Instead, there may be a proportion of the population that exhibits something called schizotypal personality disorder. So these are people who may be socially uncomfortable, who have speech, thoughts, and perceptions that may seem unusual, but that this never develops into full-blown schizophrenia. So there may be people who might have been considered oddballs or odd ducklings who might have had, who might kind of represent this less severe schizophrenia because they're genetically predisposed to schizophrenia, but maybe didn't have any of the sort of stressors that might have triggered maybe full-blown schizophrenia. And one suggestion, one of these stressors that might kind of trigger the genetic vulnerability that's been suggested is that some people, some women may end up having viral infections in their uterus that may trigger certain cases of schizophrenia. And some of the evidence from this comes from when people with schizophrenia are born, that women are more likely to have viral infections in their uteruses during kind of the month that people with schizophrenia are born. So that's kind of one of the explanations there, but there may be also other stressors within someone's life, like abuse or trauma, that may also make schizophrenia more likely to appear. Now we will discuss childhood disorders, and childhood disorders are just what they sound like. They're disorders that are marked by their appearance in childhood. So all the other disorders that we talked about, I think the earliest one appears in late childhood, but generally they are associated with adolescence or adulthood. However, these disorders are fundamentally diagnosed or significantly diagnosed in childhood and early childhood. The first childhood disorder we'll discuss is autism spectrum disorder, or ASD, which is marked by persistent deficits in communication, social bonding, imagination, and in some, but not all cases, intellectual deficits. ASD is on a spectrum of severity, right, with the most severe having difficulties with things like potty training, or, they do seem to have intellectual deficits, while on the less severe side would be something like Asperger's, which manifests itself as, to an outsider might seem like slight social awkwardness, but again, isn't this kind of large-scale deficit in ability to communicate, like not being able to speak at all. So Asperger's is something that there's been a little bit of whiplash in how this has been diagnosed in recent years. For like a 5-year period, Asperger's was considered to be an entirely independent diagnosis, but now I believe that we do now consider it a less severe form of autism instead of an independent phenomenon. So the actual causes of autism spectrum disorder are relatively unknown. We do have an understanding that genetics play a prominent role. However, we haven't really found a specific gene or have a better understanding of exactly how heritable something like autism spectrum disorder is. However, genes are obviously a crucial component. Although it's biological, there has been a rise in incidence rates over time. However, this has made people say things like, well, we have more autism now than we used to. However, the rise in incidence rates seems to be more due to diagnostic criteria than to an actual increase in the number of people who have autism. So now we include children who have less severe autism rather than just children who are nonverbal. Additionally, parents who need services for their children, right? There aren't really many services for children with disabilities in the US public school systems, especially for disabilities that aren't very well known, because there's all sorts of genetic mutations that can happen, right? But ASD is an easy diagnosis, or is an easier diagnosis to get for your kid to ensure that they can get attention and help within the school system. So there's also been a rise in incidence rates due to the fact that parents are looking for their children to get diagnosed with autism in order to make sure that they get help that they need within the school system. So we've expanded our idea of what autism is, and there are more people kind of pursuing diagnoses of autism because resources for children with disabilities are so limited. The important thing to note here is that autism spectrum disorder is not caused by vaccines. There's no evidence for this, none whatsoever. There was, how this whole vaccines cause autism debate started was because one man named Andrew Wakefield published a study with 12 children. It turns out he falsified his data and actually mistreated his patients and parents of his patients in the process of collecting data. That paper has since been miscredited and has not been replicated, and Andrew Wakefield has lost all of his credentials. This has since blown out of proportion. A miscredited and falsified piece of research has blown out of proportion, and we are seeing a rise of diseases, preventable diseases, because people aren't vaccinating their children. Vaccines are responsible for reducing deaths in children because of things like polio, whooping cough, measles, mumps, rubella, etc. We have reduced our rates of these diseases significantly in the United States because of vaccines. Not vaccinating your children or not getting yourself vaccinated will lead to rises in things like polio. Polio is horrifying. Please look up pictures. Please get an understanding of what polio is. I'm sure that you don't need a lecture on this, but it is significantly upsetting that people refuse to vaccinate their children, also in part because they're afraid their children will get autism, as though autism is somehow worse than your own child being dead or someone else's child dying because of your own lack of responsibility. Anyway, now we'll move on to ADHD. ADHD, or attention deficit hyperactivity disorder, is a childhood condition marked by excessive inattention, impulsivity, and activity. And there's two subtypes. There's ADHD with hyperactivity and without hyperactivity, where inattention is predominant. So people with ADHD have difficulties with concentration. However, they can concentrate when sufficiently motivated. So children with ADHD can also hyperfocus. ADHD has high estimates of heritability, which gives us an idea that ADHD is related to our genetics. However, there are definitely issues with our diagnostic rates of ADHD. Societal norms play a large role in how we diagnose ADHD, right? Societal expectations for children being able to sit still in a classroom relates to issues with diagnostic rates, right? It's not normal for any child to sit still in a classroom, right? That's not typical. Children actually don't learn best when they're forced to sit still for hours on end. So in cultures or in systems where children are expected to kind of act not like children, they are more likely to get diagnosed with a disorder that's related to hyperactivity. So we end up having issues with our actual diagnosis rates. However, ADHD is, of course, a real phenomenon and a real disorder, but diagnostic rates have kind of confused or muddied the issue, in part because we have a difficult time discerning what's typical child behavior and kind of what we expect from our school systems. Additionally, ADHD also gets conflated with trauma easily, because children with trauma have similar attention difficulties that children with ADHD do. So a child who is physically abused shows similar problems with attention because they're always looking for the next threat. School does not necessarily seem as important when you are scared of what could happen to you, right? So trauma is highly associated with ADHD because children with trauma or abuse backgrounds will be diagnosed with ADHD despite the fact that they don't actually have the disorder. Instead, they are manifesting symptoms of the disorder, but it has a different cause. ADHD is also not diagnosed in women at the same rates that it's diagnosed in men, even though there aren't actually differences in the sexes in actual numbers of people who have ADHD. Women have ADHD at the same rates as men. However, women tend to be diagnosed later and diagnosed less. As we wrap up and conclude, I thought that it would be good to emphasize that what is most important is you, the student. It's important to recognize that there are those who care, no matter what somebody is dealing with or experiencing. And, you know, I, as a lecturer, care about all of my students, and I know that there are friends and families who also care. UF actually has some great resources for those who maybe don't feel comfortable reaching out to friends or family, or have, you know, who want to speak to a professional. I know lots of the students who are in the, or many of the counselors who are at the CWC, and they care significantly about the students, and they are there from 9 to 5 every week. Their number is here, and again, I will post the link to their actual website. Many of you won't be in Gainesville at this time, so I might post general Florida resources as well, but this is the Crisis Center for the Alachua County, or for Alachua County. So our conclusions today are, you know, seem short in part because we spent so much time kind of breaking down multiple disorders, but our conclusions are that mental illness can be caused by genes, the environment, and also the interaction between the two. The DSM-5 is used for diagnosing mental illnesses, but also has benefits and downfalls, right? It's good for categorization and creating a language around which we can speak. However, it's not as good for, you know, kind of parsing out severity of illnesses. There are also many different types of disorders that can be grouped into different categories, and I include all of the categories again on the next slide, and you'll need to know the different types of disorders for your quiz. Here are the types of disorders again, and thank you. I look forward to next lecture when we actually talk about treatment. So today was a lot of talk about all of the different problems, and tomorrow we'll kind of touch, or tomorrow I'll touch on treatment, but you can watch that video at any time that you want. So thank you for watching, and I'll see you in the next video.